Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 42 of the OBGYN podcast. Today, we're going to do something a little bit different. We're going to be talking to Dr. Suchi Hourigan, who is currently conducting a randomized controlled trial on vaginal seeding. This has become a hot topic in recent years due to the finding that children born by cesarean delivery are more likely to have a wide range of adverse healthcare issues such as asthma and obesity. Along with this, several researchers demonstrated that these neonates had a different microbiome than babies born vaginally, and a hypothesis that this may be part of the cause of these healthcare outcomes began to generate interest. In 2016, Dr. Dominguez Bello at NYU published a small study showing that wiping vaginal secretions around the face of the neonate born by cesarean delivery could help restore their microbiome to normal. What we've not had to date is long-term studies to determine the safety and possible effect on health outcomes. So in this episode, we talked to Dr. Hourigan, who is aiming to fill in this knowledge gap. She gives us a great overview about how we got here and why it's so important. And we also get to touch upon how to build such a complex trial and what lies ahead for this new field. So let's get started with episode 42, Vaginal Seeding with Dr. Hourigan. So, hello everyone. I'm here with Suchi Hourigan, who is a pediatric gastroenterologist down in the DC area. So I think we're going to have a very interesting discussion here today. But before we get into that, Dr. Hourigan, can you tell me a little bit about yourself and where you come from and how you got where you are today?
Absolutely. So as you can probably tell, I'm from England and grew up there and did my medical training there in Oxford University. And then I came across for fellowship to Johns Hopkins, where I did a pediatric residency and a pediatric GI fellowship. And it was really in that fellowship that I became very interested in the role that our gut microbiome, or the community of microorganisms that live in our guts, how the development of it plays a role in childhood health outcomes. And that really has spurred my research interest and brought me to where we are today in this trial.
I mean, anyone who's been following even basic research, but now clinical research over the last few years has seen the rise in our knowledge of the microbiome and how important it is. So, definitely we know in adults it's a big thing, and we're learning in children. How did you, for our listeners at home, we're talking about vaginal seeding today during C-sections, but how did you jump from a microbiome of children into this vaginal seeding during C-sections? How did that come about for you?
So we know that in the first few years of life, there's critical development of a child's microbiome. And by the age of 2, you're really set for life with how your microbiome looks. And so what happens in those first few years of your microbiome development shapes your future health to come and into your adult life. And we know several things affect that, how that microbiome develops. And really one of the very first exposures that you get to your microbiome development is when you were born and when you were delivered. And so really that's how we came to the point of being interested in vaginal seeding, because it's one of the first exposures that you have that influences how your microbiome develops.
What factors down the line does that microbiome play in the child and adult life? I know obesity is one of them, but where else does it come into play in their health?
Really, the microbiome isn't just microorganisms that we carry around with us. They have really critical function for humans. So they help with how your immune system develops, how your metabolic system develops. They help to keep out bad bugs. And so we are learning associations with several different diseases. So some are to do with the gut, like inflammatory bowel disease or irritable bowel syndrome. Others are to do with metabolism, like obesity and diabetes. And we're also learning that there's a lot of connection between the gut and the brain. And we're learning about microbiome imbalances that take place in neurological conditions such as autism and ADHD. And so really the scope and the role of the microbiome, we're just beginning to understand just how important it is in many different aspects of human health.
Yeah, fair enough. I think one of the things that you just mentioned that is interesting to me is the link to IBS and that's those sort of disorders, which really seem to have skyrocketed in the last decade or 20 years. And whether that is really a issue of diagnosing it better now or whether it's an actual increase is interesting. And the microbiome may be, I think, part of that answer. So that's interesting to me.
Yes, and I think, with all of these diseases, the causation is very multifactorial, but certainly microbiome will, along with other factors, may play a role.
So when we get into the vaginal seeding, or let's step back from that, I suppose, and talking about the neonatal microbiome, I would guess there are probably a few things that go into that. One is definitely the passage through the vagina and the microbes that live in the maternal vagina and uterus. Then there would be breastfeeding and the microorganisms that you get out of breastfeeding. And then the last thing, and I guess this is kind of the opposite of, is eradicating microbiome. One of my colleagues today, when I were discussing the treatment of chorioamnionitis and broad spectrum antibiotics that many neonates get if the mother is diagnosed with that, and what effect that must have on their microbiome. So it seems like there's a whole lot of push and pull going on during that birth event.
Absolutely. So the events in pregnancy, around birth, and then after, such as you said, such as breastfeeding, really all play and have a role together in how that baby's microbiome develops. And we know that antibiotics really have a profound effect on the microbiome. And even when you stop the antibiotics, it takes a long time for your microbiome to recover. And you may have changed that development of the microbiome, the trajectory completely from what it was. So it's not just while you're taking the antibiotics, it's all the effects on your microbiome after.
Yeah. In researching for our discussion today, I did see a couple articles. One, I think, about antibiotics and the measurement of the neonatal microbiome. The other one was breastfeeding. And it did seem to have, at least in the way it was measured, it was a profound effect. And that's something we'll talk about, is how do you even measure this outcome? But in the measurements that were done, there was a really profound difference in those two things. And I was very surprised by that. I mean, the first time I heard about microbiome in the neonate and vaginal seeding, maybe it was 2 years ago. And it really seems to me like it came out of nowhere. But maybe for you and what you do, it's been on your radar longer. So when did you first really hear about vaginal seeding as something that was being done?
So certainly we first became interested in this because we know that childhood obesity and adult obesity is a critical global health problem. And when you look at the data, babies born by scheduled C-section have about a 50% increased risk of obesity, as well as other health problems such as asthma and allergies. And even though obesity is a very complex disease, if you can reduce one of the factors associated with it, it could help a lot in the prevalence of obesity. And so it's always been one of my interests, and so we were looking at different ways to prevent obesity. And we also knew this connection with C-section and obesity. Mm-hmm. Really, a few years ago, there was a seminal paper by one of our collaborators on the trial, Maria Gloria Dominguez-Bello, who at that time was in NYU, and she performed the first pilot study of vaginal seeding. And just for listeners, what vaginal seeding is exposing babies to mom's vaginal microbiome who are born by C-section, so who otherwise would have missed out on that first exposure to mom's vaginal microbiome. In that paper, she had it was a very small number of babies, but she showed that babies born by scheduled C-section, when they were wiped down with mom's vaginal flora on their face and then their body, their microbiome development started to look more like a baby who was born by vaginal delivery compared to a baby born by scheduled C-section. And so it showed that you can kind of restore this exposure that you are missing, and you can actually change that development of the microbiome, which is a really fascinating concept. And that was really when everybody became interested in vaginal seeding and moms started to ask for this procedure to be done. And while that trial was really spurred the interest and was seminal, it was very small numbers. And so it did show that you could change how the microbiome developed, but it didn't actually show if it actually improved health outcomes for those babies, such as obesity or allergies or asthma, because it would take much larger numbers of babies followed for a much longer period of time to be able to do that.
Yeah, it's an interesting point, especially about the multifactorial nature of this particular issue. But so much of the low-hanging fruit in medicine has already been captured. And what we're left with now are these complex diseases, which probably have 4 or 5 or 20 different mechanisms of causing it or contributing to it. And so I think people listen to this show on a regular basis, listen to our podcast, our Journal Club podcast. We talk about how, those kind of complex interactions require a much larger study to tease out whether the one thing that you're studying will have an effect on the disease. So I think that's what you're getting at there. You have a small pilot study that says, yes, it changes the microbiome, but what is the safety of that? What is the efficacy of that? And is that something that we should pursue further in an actual clinical setting? I think is where your study comes in.
Absolutely. And the microbiome is a really compelling target because unlike factors like the human genome, the microbiome can be manipulated to improve health. And that is also one of my major interests, microbiome manipulation. We already do studies with fecal transplant showing that you can manipulate the microbiome to improve health for children and for adults. And this is another way, vaginal seeding, to manipulate the microbiome to improve health outcomes if it is shown to be successful.
That was going to be one of my other questions about how do you think this relates to fecal transplant? Like, do you consider it to be in the same vein as that intervention, and does that kind of impact how you put the study together and your outcomes and things like that?
So in some ways it has some similarities to fecal transplant. So you are taking a microbiome or community of microorganisms and also the products that they produce that someone would have not normally been exposed to and exposing them to it. So in that way, it's similar. The differences are that with a fecal transplant, you are using stool from usually a known or an unknown donor, but here with vaginal seeding, you are trying to restore exposure from the actual mother of that baby to the baby. It's not somebody else's microbiome. It was the microbiome that they were intended to have if they were born vaginally.
I see what you mean. So instead of being almost like a treatment, it is more of a, like you said, a restorative to nature, where we kind of bypass that by intervening with a C-section. This is going back and restoring what they would have had if they delivered, quote unquote, normally or vaginally.
Absolutely.
That makes sense.
I see it more of a restorative process compared to fecal transplants. However, in the view of the FDA, they consider fecal transplants very similar to vaginal seeding, and that's why we had to go under such extensive work with the FDA to get this trial approved.
Yeah, I could see from their point of view. I mean, you are doing something to the neonates that isn't happening to them by nature because we're bypassing it. And I can also see the other side where you're coming from and say, well, this would have happened to them if they had a vaginal delivery, so why is it a big deal? I can see both sides of that.
Absolutely.
So you get this idea to do, you study vaginal seeding. You read the other papers, and you said, okay, we want to be the people, or one of the people who do this, randomized control trial, which we'll get to what you're going to do here, and you want to tackle this. How did you go about pulling a team together for that? Getting that through your IRB? What challenges did you face in that? Like, just how did the whole thing come together? So
we knew we wanted to do this study, but we did not want to work in isolation. We wanted experts on the team. And so so as well as my expertise in microbiome development and fecal transplants and so on, we are collaborating with Dr. Maria Gloria Dominguez-Bello, who is now in Rutgers, who was the doctor who invented this process. And then also with Noam Weller at Johns Hopkins, who is an epidemiologist involved in microbiome development and childhood health outcomes, and who helped to design this trial too. And so the three of us together have came together as a team. We also have, critically in our team, we have our clinical lead, Varsha Diopajari, who is an OB-trained physician, and she actually performs the vaginal feeding on these babies. And then we have a host of other members of our team that have helped to pull this together. The application to the IRB, what we realized is that we needed FDA approval. So to get a interventional new drug application, which really held the trial up from starting for at least 6 months. But then we now have all of that, and we have begun to recruit patients.
I saw that you enrolled your first patient back in middle August, September, and then?
Yes.
And where are you enrolling from? Where are you capturing these people?
So currently, it's all at the Inova Fairfax Hospital. This is our largest flagship hospital of the Inova Health System, where we have thousands of deliveries a year and a very high cesarean section rate, so about 40%. At least for the moment, for the pilot part of the study, and while we're assessing safety, we will remain just at this one location. But as we expand to get the numbers that we want to look at other childhood health outcomes, such as obesity or allergies, we may also offer this trial at other locations.
Okay. So I think we've danced around it enough. Well, if you can, why don't you describe to me what your study actually is, how you're performing it, and what you're looking at?
So we are recruiting moms who are scheduled for C-section, and they have very strict inclusion and exclusion criteria. But really, the main focus is to exclude anybody with any infectious risks that they may pass on to the baby. Okay. Once they've agreed to be recruited on the day of the C-section, they are randomized, and so half of the babies will receive vaginal seeding, which is being wiped down with mom's vaginal flora, and this occurs after birth, after they've had delayed cord clamping, but before they go skin to skin with mother. Right. And half of the babies will be wiped down with a saline placebo, so a gauze with saline on. This all but one member of the study team are blinded, and so we do not know which babies receive which procedure. Okay.
And the moms don't know either, and the babies don't know.
The moms don't know either, and of course the babies don't know. And then in terms of the nuts and bolts of how we do this, which everyone's very interested in, so when the mom is being prepared for C-section, we insert a gauze into her vagina, and we leave it there for around an hour. And then very importantly, prior to when she receives antibiotics for the C-section, we remove that gauze. And then when the baby's born, that's when we swab them with either the gauze or the saline placebo. And we really want to capture this baby with the process before they go skin to mom, because we want that first exposure to be the vaginal microbiome, not the skin microbiome of the mom.
Right. Which is how it would be in vaginal delivery.
Exactly, yes.
All right. And then you did mention your outcomes a little bit, but I'm cribbing from your clinicaltrials.gov posting. But so your primary outcome, I believe, is the intestinal microbiome of the neonate at 3 months.
Yes. So we're really looking at a few outcomes. Okay. So the first is looking at how the intestinal microbiome develops, and we're following these babies over 3 years and getting serial stool samples from them. Okay. And so we want to see whether the microbiome development of those who receive vaginal seeding compared to those who get the placebo, if they differ. And if they do, is that difference sustained up until 3 years of age? We are also looking at childhood health outcomes, with the main one being obesity. And so we hypothesize that the babies that receive vaginal seeding will have a decreased risk of obesity at 3 years of age compared to those that get the placebo. Okay. And then, of course, we're also looking, is this procedure safe?
Right. So how often are you doing the fecal samples on the neonates?
So in the first year of life, we do them very frequently because that's where the major microbiome development occurs. So we have 6 samples in the first year of life, and then we have 1 at 2 years of age and 1 at 3 years of age.
Okay. You said previously that by 2 years of age, that typically is when the microbiome is kind of settled?
Yes, okay. Somewhere between 2 and 3 years of age.
Right, so that makes sense.
But the really rapid development occurs in the first 6 months.
So, again, in the clinicaltrials.gov, it says that 3 months is your primary outcome. Now, maybe that's different, your final project, but I'm curious, what is your primary outcome And how did you choose that time point or that outcome as your primary?
Yeah, so I mean, our primary outcome is actually 3 years,
Okay.
looking at obesity and the final microbiome development. But those first 6 months of life, as I mentioned, is when the critical microbiome development occurs, and we want to see if vaginal seeding changes the trajectory of that development.
Okay. The couple of the questions I had about your outcomes that you were looking at. One is again in the clinical trials, it mentions immune regulation is one of the things that you're studying, and I was wondering what actual factors are you looking at to study immune regulation in these babies?
So you can look at several immune factors and antibodies and so on in the stool samples we're collecting.
Okay.
We are, however, currently these stool samples, we will examine the microbiome, but the additional stool samples will be biobanked. And so we can look at immune regulation and the products, what we call metabolomics, which are the products that the bacteria produce. We can look at those in the future.
Gotcha.
After the main outcomes of the trial.
All right, that makes sense. And then the last thing, and you mentioned this about adverse outcomes, is obviously at the end of the day, even if you don't say that this is beneficial or it's not conclusively beneficial, as long as it's not harmful to the babies, then it's not a terrible thing to do, right? So, what adverse events are you expecting, or maybe none? But what are you looking at to make sure they don't occur?
Absolutely. So after that first pilot paper by our collaborator, several mums came and asked for this procedure to be done. However, or sometimes they were doing it themselves. However, several organizations, including ACOG, the American College of Obstetrics and Gynecology, really cautioned against this procedure. They were worried about safety, really in terms of transmission of infection from mother to baby, and also questioned whether it would benefit health outcomes. And they suggested that mums not do this until it really has been studied in the context of an IRB-approved trial, which is what we have here. The major outcome, the major adverse events or safety aspects that we're looking at are infectious risks to baby. And so really the moms are screened very carefully. So if a mom is group B strep positive, they cannot be in the trial. If they've had any history of infections, sexually transmitted diseases in pregnancy, they're also excluded. We have gone one step further out of an abundance of caution, and also as recommended by the FDA, that we screen again for infections or at 35 weeks of gestation. So we screen again for HIV, hepatitis B, chlamydia and gonorrhea. All the tests that mom would have had right at the start of her pregnancy, we do them again really close to delivery to make sure she has not acquired anything new during the pregnancy.
Okay.
And then after the baby's been born, we follow that baby very carefully for if they develop any signs of infection. Really, the highest risk is in about the first 6 weeks of life, but we follow them all the way till 3 years of age, looking for adverse events. And also for the mother, they would not normally have a gauze placed in their vagina, and so we check that she is okay after the procedure. There is no adverse event. She's not having a lot of pain from it, and that she doesn't get any infections from that gauze being placed there.
I think that makes a lot of sense. I especially like the 35-week checking again. I think that, when we do our journal clubs, one of the things we always talk about is, let's say what we're going to hope that your study shows what you're hoping for. And so I say it's a result that says maybe we should do this vaginal seeding. We always say, okay, well, who did they include in the study and who did they exclude before you start applying it to your patient population? So it's very important to me to say, okay, well, you're excluding anyone who has GBS, which is, I think most people would agree with, but you're also testing everyone again at 35 weeks. And so if we want to take your hopefully good findings and apply them everywhere else, we have to make sure that we follow a similar protocol if we want to expect the same results. So I think that's always important to keep.
Yes, absolutely. I agree. And, a lot of moms, while we're screening them, do get excluded. A lot of moms who are scheduled to have C-sections do get excluded because of these criteria.
So one technical question, I suppose. Let's say you do your screening at 35, 36 weeks, and then it comes in with a non-scheduled C-section, goes into labor at 37 weeks, and you don't have your results back yet, do you exclude her from the study if the results aren't back already?
So we exclude if the results aren't back, but we also exclude if anyone's gone into labor, because the biggest risk is for scheduled of the adverse health outcomes for the baby is for babies born by scheduled C-section, because they get no exposure to mom's vaginal microbiome. The presumption is in emergency C-sections, or if there's any labor, that baby probably does get some exposure to mom's vaginal microbiome, even if it is not complete like a vaginal delivery.
I think, again, for my listeners, I think that's a very important point when you're talking about designing a study, is if you're looking for an outcome and you know it's maybe a rare outcome because maybe the microbiome only contributes a certain amount of to your obesity and asthma, that you want to maximize the effect that you are going to see. And so by taking women who are only the scheduled C-section, have no labor and therefore presumably no exposure of the neonate to the mother's vaginal microbiome, you are increasing the chance that you're going to find a result, just because now you're going from no microbiome exposure to all or none. So I think that's pretty important way when you're designing your study. So let's say you find a positive result here, and there is a benefit and no risk to the baby. Maybe it's a small benefit, maybe it's a big benefit. What's your next step from this study, which of course is probably 4 or 5 years down the line? But what do you think the next step would be after this?
So I think, firstly, if this study does show benefit to babies and decreased risk of obesity, this really may be enough to change some of the practice of obstetrics as we know it. So providers could, provide life-saving care with C-section, but decrease but also with this kind of simple process, decrease the risk of adverse health outcomes to those babies by vaginal seeding. Of course, they would have to follow the same kind of strict criteria that we outlined in the trial. Moving beyond that, though, we also are very interested in the mechanisms of how vaginal seeding works. And so all the samples from this trial that are being biobanked, we're going to be studying them very closely to see what it is in the vaginal microbiome that actually causes that decrease in risk of obesity, and to see if it can be replicated in, if there can be products made potentially that help decrease obesity in patients that are not eligible for the trial.
Okay. I mean, when you have part of biobanking, and that's for those who've done an IRB with that, that's a whole another segment of the IRB to give permission to biobank. But having all those samples there, especially as technology advances and we as a basic science group learn more about how to analyze the bacterial breakdown products and all that stuff, I can only imagine that the number of tests and ways you can analyze that in the next 5 or 10 years is only going to expand.
Absolutely. And so really in the last 5 years alone, there has been a huge development in the type of sequencing we can do of the microbiome, and learning about its functions and the products that those bacteria, mainly bacteria, are making. And so really in this trial, for the first part of the trial, looking at microbiome development, we will be doing a basic screen of the microbiome by something called 16S sequencing, which really tells us are bacterial communities different in those that received vaginal seeding compared to the placebo, and then also if there was uptake of the mum's vaginal microbiome to the baby, because we collect the vaginal swabs from the mum. Okay. But moving beyond that, we hope to be able to do much more detailed sequencing and analysis to look at the microbiome of those in those samples.
So you're also going to look at the actual gauze, the samples from the gauze as well.
Yes, and I didn't mention it, but we also have skin samples from baby and mum to see to look at the uptake on baby skin of mum's vaginal microbiome.
Very interesting. I have maybe another ignorant question for you, but you mentioned GBS being an exclusion criteria, I think, for most people, obvious reasons. But, we do have, obviously, women who deliver vaginally, they get penicillin beforehand to combat the GBS neonatal sepsis. Do you know of any studies that have looked at the microbiome in those babies that got exposed to penicillin, but yet still had a vaginal delivery?
So there are no direct studies, but what we do know is that babies that get peripartum antibiotics, which is antibiotics around the time of delivery, be it for C-section or group B strep prophylaxis or for other reasons, they do have an increased risk of obesity later. And we hypothesize that it's because they have perturbations in their microbiome development, although there are no direct studies to show that.
Okay. It would be a tough one to comment anyway, because you can't do a vaginal swab, obviously. The whole reason you're doing the penicillin is to not give them GBS. But yeah, that's a tricky one. Interesting. Anything else you want to add about the study? Any other parts that we didn't discuss or facets that you think are interesting?
No, so I think we have covered most things. The only thing I want to say is, as well as looking at obesity, we are collecting data on which children develop allergies and asthma and other adverse health outcomes associated with C-section. And then with microbiome development, there are many, many factors that contribute to it. So we also carefully follow what the baby's feeding. Are they getting breastfed or are they getting formula? When solid food is introduced, if they get ill, are they receiving antibiotics? And we're going to include all of those other factors that affect microbiome development in our final analysis.
What software are you using? RedCap, or how are you collecting all this data and keeping it all? You're collecting a ton of data over a long period of time.
Yes, so we use RedCap as our primary data collection method. One of our collaborators in the trial has also designed a survey that we use, that mums use on a phone app that is HIPAA compliant, to try and make it easier for mum to give us this information every time we ask for it. And then that will be put into the RedCap database.
And I'm assuming you have a research coordinator who is making sure that people follow up and they get your samples and all that stuff?
Absolutely. The team is large. We have a wonderful microbiome research manager called Shira Levy, and then several research assistants working on this project.
Well, I mean, just getting a project like this off the ground and getting to the part where you're enrolling women is a huge accomplishment. So I just want to congratulate you and your team on doing that. I've been involved in some of these.
Thank you very much.
Don't go anywhere because one thing or another derails it. So I'm just very impressed by that.
Well, thank you. It's been a lot of effort and it has taken longer than we expected to get to this stage, but we're very excited that the trial is up and running and we're recruiting, and we're having a lot of interest from the public in this study coming to see if they're eligible for the trial.
I mean, I can only imagine that, because I tell you, like, after that first paper came out of NYU, as you said, we had women all of a sudden overnight who were lining up to try to do vaginal seeding. And so the demand for something like this, or anything women can do that I think will help their babies, which I think is or it could be parents, doesn't have to be women, is just such a natural instinct that there's bound to be just excitement about this. So unfortunately, we all have to wait 3 to 5 years to hear your results, but I think we'll all be waiting with bated breath.
And I agree with you too. Moms will do anything to help their babies, and it's not just in childhood, but if this is effective, we know that childhood obesity lasts into adulthood, and so it will be helping them for the rest of their lives.
Well, I really want to thank you for spending the time to talk to me about your project. I found it very interesting. I think the people listening to the show will feel the same way about it. Before we go, is there anything else that you want to add? Any other things that come to mind that you think are interesting?
No, we are all waiting to see the results of this trial and how it might impact healthcare for children in the future.
Okay. Well, like I said, thank you very much. This was Suchitra Hourigan down in Innova in Fairfax, Virginia. And I, again, want to thank you for spending the time to talk about your randomized control trial for vaginal seedings on the microbiome of neonates. It was very interesting, and thank you for your time.
Thank you very much. It was great to talk to you.
I want to say thank you again to Dr. Hourigan, and I had so much fun doing the interview, and I hope you all had as much fun listening to it. If you want to find out more about this study, you can go to her clinicaltrials.gov site, which is in the show notes. And also, if you want to get in contact with Dr. Hourigan to discuss the microbiome or vaginal seeding or anything else, there's also a link in the show notes to do that. So again, thank you, Dr. Hourigan. I wish you well in your study, and I'll see you all next time.